Good afternoon, everybody. It's my pleasure to welcome you to Grand Rounds today. We will be getting started in a few minutes, and I'll first take the honor of introducing Dr. Nicholas Breitbord, who's our speaker today. Dr. Breitbord is an assistant professor of psychiatry at the University of Arizona and director of the Early Psychosis Intervention Center, Epicenter. Nice and catchy name. Dr. Breitbord received his PhD in psychology from the University of California in Los Angeles and completed his clinical internship at the Yale University Training Program in Clinical and Community Psychology. Following the completion of his doctoral program, Dr. Breitbord served as the project director for the Specialized Treatment Early in Psychosis STEP program at Yale University. Dr. Breitbord has been awarded numerous prizes for his research, including the Charles Hughes Fellowship in Cultural Psychiatry from the Society for the Study of Psychiatry and Culture, and the Michael Goldstein Distinguished Research Award from the UCLA Clinical Psychology Program. He's also been distinguished with other awards locally, some of those for teaching as well as for research. He's been here in Arizona as well. Dr. Breitbord's research and clinical interests include cultural and familiar influences on the course of psychotic disorders, early intervention for psychotic disorders, health outcomes among family members caring for a relative with a psychotic disorders, and statistics and research design. To date, his research has been funded by the National Institute of Mental Health, the Institute for Mental Health Research, the Foundation for Psychocultural Research, and the Connecticut Department of Mental Health and Addiction Services. Dr. Breitbord does not have any commercial conflicts of interest to report, but as I mentioned, those institutions and foundations that have provided funding to support his research are also listed in his slides. Please help me welcome Dr. Breitbord.
Good afternoon, everyone. So as Dr. Moreno was mentioning, we can start off by going through a quick list of the people who've been nice enough to fund me over the years. Today I'm going to be talking about the concept of expressed emotion. Expressed emotion is considered to be or it's often operationally defined as being a measure of the climate of a familial environment. But really what we're looking at with expressed emotion is 5 specific behaviors displayed by caregiving relatives to the relatives who are suffering from some sort of chronic illness. These include critical comments directed towards the ill relative, emotional over-involvement directed towards the ill relative, hostility, positive remarks, and warmth. So you can see there are some indices of expressed emotion that we would think of as being negative and others that we would think of as being pro-social or positive. Now, the gold standard for assessing expressed emotion, these 5 indices, is called the Camberwell Family Interview. This is a 1 to 2.5 hour semi-structured interview that's administered to the caregiving relative in the absence of their ill relative. And what you're assessing here is getting them to talk indirectly about their ill relative by asking them to talk about when their illness first started, what did they first notice, who handles various tasks around the house. And indirectly through these, we're able to tap into these 5 indices of expressed emotion. Expressed emotion typically gets dichotomized such that we'll identify certain individuals as being high in expressed emotion and being low in expressed emotion. To be considered high in expressed emotion during this interview, you need to make 6 or more critical comments to your ill relative. You have to score a 4 or greater on a 6-point emotional over-involvement scale that ranges from 0 to 5, or you need to display any amount of hostility towards your ill relative. So there are many different roads to fall under this umbrella of high expressed emotion, and we can imagine that many of these look very different. The high critical relative, we could imagine, looks very different from the relative who is over-involved in their care of their ill relative. So the way that this research has typically gone is that the researcher will meet with caregiving relatives, will assess their expressed emotion status, and then following that, track health outcomes in their ill relatives prospectively. Typically, these studies go pretty long. We're looking 6 months down the road, a year down the road. Some have even gone as far as 20 years down the road. And the typical finding is that ill individuals who are exposed to these familiar environments that we would describe as being high in expressed emotion are more likely to suffer negative health outcomes during this follow-up period than ill individuals who are exposed to familiar environments in which the presence of these variables is low. So why is EE important? Well, it predicts the course of illness for many, many things. So this is a list of every psychological and physical illness that I could find that has at least one study to date indicating that expressed emotion is a reliable predictor of the course of illness. And you can see this is quite a large list here. In schizophrenia alone, it's predictive not just in schizophrenia in general, but among people with first episode psychosis, people with chronic long-standing schizophrenia, people with schizophrenia with and without substance abuse disorders, and even in adolescent psychosis. What's interesting, I won't bore you with going through this entire list, but on the far right of the screen on the bottom, there have been a few studies that have actually looked at expressed emotion as potentially a predictor of the onset of the illness. So not predicting worse illness, but predicting the onset of the illness down the road. And a few studies have suggested that it is associated with the onset of the illness. So high expressed emotion is associated with a greater likelihood of developing psychosis among adolescents who are at risk already. Typically that means that they have a family member who they themselves has psychosis. It's also a risk factor for the onset of major depressive disorder among children with a parent with that same illness. And it's a predictor of ADHD in children in general in one study here. So there's something kind of special about this variable that seems to be uniquely associated with the course of illness for pretty much every disorder that has been tested for to date. So how does EE work? How does it predict the course of illness? To date, the model that's typically used to describe this is referred to as the stress diathesis model. The way this works is you have a caregiving relative who has some pre-existing vulnerability in themselves. They're then exposed to the stressor of serving as a caregiver for their ill relative. So we have the diathesis, the pre-existing vulnerability, we have the stress, and this in turn leads to the expression of high EE. Their ill relative, who also is presenting with some sort of pre-existing vulnerability, in this case the most obvious of which would be that they, in most of these studies, have already been diagnosed with some sort of chronic mental or physical illness. When they're exposed to EE, which is hypothesized to be the stressor, this is what's thought to lead them to have negative health outcomes here. Unfortunately, a bit of a vicious cycle develops here in that these bad health outcomes create more stress for the caregiver, which then leads them, on average, to display more high EE behavior, which then leads to a worse course of illness for their ill relative. And this pattern can continue over and over again within families where a relative has a chronic illness. So, despite the potential of EE and nearly 4 decades of research suggesting that this is a useful predictor here, EE is not without its critics. Agnes Hatfield has pointed out that EE theory really isn't a departure, or enough of a departure, from some of the older theories of families and psychosis in particular, where family members were thought to be the cause and to be who should be blamed for their ill relative's poor course of illness. As an example of that, I've put up the part of the first page from Frieda Fromm-Reichmann's seminal paper where she identifies the schizophrenogenic mother. This is the concepts that Hatfield and many others have noted, or have at least criticized EE as not being far enough away from, really still tapping into these problematic hypotheses. But it's not just these theoretical criticisms that we're seeing. EE research doesn't seem to be as noteworthy or popular. So this was based on a search that I did of the PubMed and PsycInfo literature. And I looked at where are EE studies being published by decade. And I divided this up into other, which is all journals, or the top journals, which I defined as the top 10 journals in psychology and psychiatry based on their 2-year impact factor. So these are things such as the Archives, American Journal of Psychiatry, Psych Bulletin. And what we see over time is that since EE first started being published about in the 70s, is that while this was something that got a lot of attention, it was published in top journals at first, this has declined dramatically over the years. Even as the number of papers has increased, fewer and fewer are getting into these top journals. So again, EE might be problematic because it's tied to these theories in psychiatry that caused a lot of blame and hurt among caregivers, but it also might just be something that we're not interested in anymore. So this brings us to the title of my talk today, Wither Expressed Emotion. This is sort of a play on words. There are two words there, wither and wither. The first wither with a H at the beginning refers to the idea of to what place or where. So, whither goest thou, one might say. The other form of wither without that H, which is a verb, means to shrivel or fade or decay. So the title really gets at this idea of where should EE research go in the future, and is there the possibility that we don't need to study this anymore here? Really, is there anything else to learn about expressed emotion? What I'd like to suggest is that there is, and I'm going to highlight 5 areas where there are very important but unanswered questions in the EE literature. I wish I could give you answers to all of these, but what I hope to do here is maybe whet some of your appetites that these are in many ways important topics that can be addressed in the literature for those who might be interested to. The first one I'd like to talk about is this idea of investigating causality and mechanisms in this relationship between expressed emotion and poor health outcomes. So for a long time, EE was thought to have a direct relationship to poor health outcomes. And this is evident in this section that I pulled from a paper from Sayward, where he quotes a number of some of the early studies on expressed emotion and some of the phrases they used to describe its relationship with a poor course of illness. So Vaughan and Leff in '76 talk about EE as being associated with relapse, in this case schizophrenia relapse, independent of all other social and clinical factors. That's a pretty powerful statement. Leff goes on in 1976 to talk about there being a direct link between EE and relapse. And this idea of a direct causal link between expressed emotion and poor health outcomes has really been dominating the field, even though it hasn't been investigated very much systematically. If we turn back to this stress diathesis model of expressed emotion, which is still at this moment is the dominant theory behind what's going on, we can see that there is a direct relationship right here, or assumed direct relationship, between expressed emotion and poor health outcomes. So this idea is very much present in the literature. There is a reason why it's there, too. This isn't coming out of nowhere. We know in general that stress is associated with poor health outcomes. Bruce McEwen has really taken the lead of this as of late, highlighting the positive associations between high levels of stress and negative health outcomes in general, and suggesting that this is mediated by the physiological toll that results when systems geared toward coping with stress are repeatedly activated over and over again. Taking this back to the EE literature, we know that interactions between individuals with chronic illness and relatives who display high levels of expressed emotion are typically very stressful for the relative with the illness. We see this across various measurement styles. So if we ask them a subjective report, how stressful was that interaction with your caregiving relative? Well, the people interacting with relatives high in expressed emotion are more likely to rate that as being more stressful than those who interacted with caregivers who are low in expressed emotion. But we also see this in terms of physiological mechanisms, getting back to this McEwen model of this repeated activation of the physiological systems geared to reducing or coping with stress. So if we look at skin conductance, if we look at blood pressure, if we look at cortisol, all of these biological markers suggest that when you have a chronic illness and you're interacting with someone who is very critical or over-involved or hostile towards you, this is a stressful experience. We also know that in these family interactions, which are stressful, that we see greater expression of symptomatology among individuals with a chronic illness. And the clearest evidence for this comes from studies of schizophrenia, which have shown that if you take an individual with schizophrenia and have them interact with their relative, well, if that relative is high in expressed emotion, the individual with schizophrenia is more likely to display greater levels of psychotic symptoms during that interaction than an individual with schizophrenia who's interacting with a relative who's low in expressed emotion. So the interactions are stressful. We're seeing greater emergence of symptomatology in them. But the picture's not as clear as that. And I'd like to suggest that there are some serious concerns about the stress diathesis model of expressed emotion. The first, and I think most problematic of it, is that expressed emotion is not predictive of other stress-related outcomes among ill individuals. Clearest evidence, again, comes from schizophrenia, and most of the research we'll be talking about today comes from schizophrenia, where the majority of expressed emotion research has been done. So we know that among individuals with schizophrenia, even though expressed emotion will predict the worsening of psychotic symptoms, it isn't predictive of other stress-sensitive outcomes, such as cognitive performance. Among individuals with schizophrenia, we also don't see a relationship between expressed emotion and health outcomes and other non-psychosis psychiatric outcomes, like depression or anxiety, that we know are very sensitive to stress. If stress was really what's driving this relationship here, well, we would expect all of these things to get worse, but it's only certain outcomes that get worse. The other potential limitation about the stress diathesis model is that it's really unclear if it's the expressed emotion in the family environment that's what's stressful for the ill relatives. It could potentially be something else that is co-occurring simultaneously with this criticism, emotional over-involvement, or hostility. In support of that, we've seen that the evidence is mixed in terms of whether people experience an increase in physiological markers of stress when we look at specifically how those measures are tied to the instances of high expressed emotion behaviors, such as criticism or emotional over-involvement or hostility. So for example, if we look at an interaction between a relative with schizophrenia or another chronic illness and their caregiving relative, when the caregiver makes a criticism to them, what we would think of as being expressed emotion, there's no clear relationship between that criticism and increases in physiological markers of stress. We know that the ill relative will say that that interaction was more stressful, but criticism doesn't seem to be driving that relationship. We also, if we look at expression of symptoms, these aren't necessarily happening in temporal relationship with these expressed emotion behaviors. If EE is a stressor, we would think after the expressed emotion, that's when you'd see the symptom. It's not always how it works out. And finally, we know that if we reduce expressed emotion in families, if we can bring down the level of criticism and hostility and over-involvement, that's a good thing. But it doesn't necessarily change the level of physiological stress that ill relatives experience in their interactions with their caregivers. What that means is, let's say we have an individual with schizophrenia who's interacting with a relative who's high in expressed emotion. We would expect to see that a number of these physiological stress markers would be very responsive, and that this ill relative would describe that interaction as being very stressful. If we do a family intervention, help that caregiver become less critical, less hostile, less over-involved, and then repeat that interaction again, we'll still see these same physiological responses in their ill relative, even though the EE in many ways is gone, or at the very least reduced. So this brings us to the idea of the third variable problem that gets talked a lot in research. In this cartoon, we have a young child on a plane who says, "Can we stop turning on the seatbelt sign? It makes the plane fly bumpy." This is the idea of the third variable problem, that you have two things happening simultaneously, and you assume that there's a cause and effect relationship between the two, when in fact a third variable that we don't know about, in this case the young child doesn't know about turbulence, is really causing both things to happen simultaneously here. So could there be a third variable here in this EE relapse relationship? Well, my colleagues and I back in Los Angeles have begun to explore this, and we've gone through the EE literature and have become particularly interested in caregivers' perception of their ill relative's agency with regard to the control of symptoms in their illness. Why did we get interested in that? Well, we know that expressed emotion is associated with caregivers' perception of their ill relative's ability to control their symptoms. If you're a caregiver and you view your ill relative as very able to control their symptoms, even though they're not, because, or maybe you're overly optimistic about their ability to control their symptoms, when they don't, or when symptoms appear that aren't under their control, well, you're more likely to blame that individual for the expression of these symptoms. And that blaming can often lead to criticism and hostility. We know that in families, when you're suffering from a chronic illness, exposure to this belief from family members that you really lack the ability to have a meaningful effect on controlling your symptoms is a psychosocial stressor for ill individuals, that they are bothered by this and that this makes them uncomfortable. More importantly, we know that, at least if we're looking at the schizophrenia literature, that this exposure to this idea of limited agency can produce some of the factors that we associate as being causal factors in the occurrence of worsening of psychotic symptoms. This is in particular creating processing capacity overload, so really overwhelming the cognitive skills of these individuals, and creating autonomic hyperarousal. Exposure to these beliefs from individuals that you don't have the ability to do certain meaningful things in your life triggers these same exact factors that we know are causally associated with the worsening of symptoms in schizophrenia. And if we're talking about hyperarousal and overload of cognitive abilities, I think it'd be fairly reasonable to speculate that these are probably tied to the worsening of many illnesses. So based on that, my colleagues and I, we've now tested in a couple studies a model of whether expressed emotion and agency and relapse are really an example of the third variable problem. And our model has tested the idea that we see this relationship between expressed emotion and poor health outcomes, but maybe that's just due to the fact of a third variable, in this case caregivers' perception of their ill relative's agency, that leads to both expressed emotion and to relapse. In this model, we've looked specifically at individuals with schizophrenia, and we've validated this model now in two different studies, one among recently hospitalized Euro-Americans who are early in the course of their illness, and then in a study of community-dwelling Mexican Americans with more long-standing illnesses. So we now have two replications of the idea that a third variable is really accounting for this relationship, or apparent relationship, as we would argue, between expressed emotion and relapse. What's interesting, though, is across these studies, as a bit of a side note, is that the direction of the association between agency and poor outcomes and expressed emotion varied. So what do I mean by that? Among the recently hospitalized Euro-Americans who are early in the course of their illness, what really seemed to be driving this relationship was a belief by the caregivers that they had limited agency to control their symptoms. So having that perception was predictive of caregivers being high in expressed emotion, and having that perception was also predictive of relapse among the ill relatives. In the Mexican American sample, it was the opposite direction. So caregivers who perceived their ill relative as having more control over their symptoms, these were the ones who tended to be higher in expressed emotion. And that was also the belief that tended to be predictive of relapse about 9 months down the road for these individuals with schizophrenia. And we're still working on trying to tease out why that's happening. Unfortunately, we have two variables that differed among the two groups. Stage of illness, with people early in the illness and late in the illness, and then we had an ethnic difference in terms of Mexican Americans versus Euro Americans. And we're currently working on some additional data analyses and actually a new study now to really try and tease out which one of these variables, or maybe both, might be explaining that difference in the relationship there. So with that note highlighting this potential cultural variation in our third variable model, in EE research in general, there is much need for further research looking at cultural variation in this association between expressed emotion and poor health outcomes. We know that high expressed emotion seems to be detectable pretty much anywhere you look for it in these families caring for relatives with schizophrenia or other chronic illnesses, but the frequency of it varies dramatically across ethnic groups. So here's an example of what that variation looks like, where British Pakistanis to date have the highest rate of high EE in a study where 80% of them were characterized as being high in expressed emotion. And rural individuals in India, only 8% of them reach this high expressed emotion. Something's going on here. All these studies use the same measure to assess expressed emotion, and in fact, the vast majority of these are actually the same group of researchers. So this doesn't appear to be a methodological issue here. We're tapping into something that's different among families who are caring for a relative with a chronic illness. And because we know high EE is predictive of relapse, well, it might be interesting to know why only 8% of rural individuals in India are developing high expressed emotion. If we could figure that out, that potentially has large implications for treatments. But it's not just the frequency of how often high EE occurs that differs across culture. We also know that there's some important differences in the relationship between high expressed emotion and poor health outcomes across different groups here. So, for example, most of the studies in expressed emotion, or at least the early ones, were done in Europe and North America. And these studies among white Euro-American or European individuals really found that criticism was the key index in expressed emotion in terms of predicting relapse. And for a long time, there was a lot of talk of criticism being where we should really focus our family interventions as a result of this. More recently, though, as we've begun to look at other populations, we see that criticism isn't the most important predictor of poor health outcomes for everyone. We did a study among Mexican Americans. Studies have been done in Japan suggesting that over-involvement is really the key familial variable that's predictive of poor outcomes in these individuals. And in the study by Wig and colleagues in India, it was hostility that really seemed to matter the most. So what is it about these disparate set of variables and these different settings that leads caregivers to respond in potentially culturally specific ways that in turn may have a negative influence on the course of illness? This would be a key question to tease out here. To give you an idea of how much what this really looks like here, even within how much variation we might see within a single population here. So this was a group of Mexican Americans that we studied in the Los Angeles area, and we divided them based on their level of enculturation in terms of their fidelity to what was defined by the measure as Mexican American culture. All these enculturation models or assessments are fairly problematic, but ignoring that for the moment now, what was interesting is that we found among individuals who were low in their fidelity to Mexican American cultural values. These are people who tended to be more in line with what we might think of as American or white American cultural values. Well, we saw the expected relationship between EE and relapse, looking at their relatives with schizophrenia. The relatives who were in the high EE family environments were much more likely to suffer a relapse than the individuals who were in the low EE family environments. But among the Mexican Americans who were high in Mexican enculturation, there was actually the exact opposite relationship here, where low expressed emotion was actually predictive of worse outcomes, and high expressed emotion was predictive of better outcomes. So why might this be? What we've speculated here is that we know among Mexican Americans the key factor that seems to be driving high EE, and the most classic way that's expressed is by emotional over-involvement. And in all honesty, the way that emotional over-involvement is defined on the Camberwell family interview is very much a British version of what we might think of as emotional over-involvement. And we know that the level of involvement one has with one's families varies by culture. So with that caveat in mind here, one thing that we are speculating here is that among the high enculturated Mexican Americans, where family relations, especially close family relations, were particularly important, at least according to our measure of enculturation we looked at, that actually having a relative who is more involved in your care, what might be labeled as over-involvement by the Camberwell family interview, but it's really just involvement here, that might actually be a protective factor. You might need to have a relative who is more likely to help you out in terms of getting to hospital appointments, helping you manage symptoms, navigate the bus system, things like that. And not having that relative's involvement might actually be problematic. We should also know that most of these individuals who are high in Mexican enculturation were Spanish-speaking individuals only. So here they are, Spanish-speaking individuals in Los Angeles, trying to navigate what is not a very friendly world for low-income immigrants. And having family involvement, well, that would make a lot of sense for high family involvement to be necessary and potentially protective in an environment like that. For these individuals who are low enculturated, the majority of which were more English-speaking and might be able to navigate the maze that is Los Angeles a little bit better, well, they might not need that much involvement anymore, and in fact, over-involvement might be potentially stressful. So the next possible area for growth in this area I want to talk about is actually looking at the association between expressed emotion and positive health outcomes. So far, most of the talk has really been focusing on EE as a negative factor, but it can be positive as well, too. High EE, we might say, could that potentially be a good situation? That slide among the Mexican Americans I just showed suggests that for certain people, high EE might be helpful. And what about the pro-social indices of expressed emotion, warmth and positive remarks? So far, all I've been talking about has been criticism, emotional over-involvement, and hostility. And that's really where most of the research is to date. But what about these potentially forgotten indices here? So is high EE always a bad thing? Well, it doesn't look like it. We know among individuals with borderline personality disorder, having a caregiving relative who's high in emotional over-involvement is actually associated with a better prospective course of the illness. These individuals typically do better in terms of their global level of functioning, and they're also less likely to end up in the hospital. Among individuals with schizophrenia, where it's very clear that in most cases, EOI is predictive of worse health outcomes, we actually know that, or health outcomes in terms of symptoms, we know that it's actually associated with better health outcomes in terms of social functioning. That's a bit of a quandary there. Why would it be predictive of bad symptoms but better social functioning here? We've begun to sort of try and break down this idea of emotional over-involvement a little bit more to do a little bit more fine-tuned analysis of its relationship with relapse. This was on the Kusama study, which was done in the 80s, looking at Mexican Americans caring for a relative with schizophrenia. In this sample, emotional over-involvement was the key index of expressed emotion that was predictive of relapse. And what we wanted to look at in this was really more of a methodological paper. We were curious about the assumption of a linear relationship between EOI and relapse. Is it really that the more over-involved you get, the worse your symptoms are? Might being completely uninvolved, an EOI score of 0, might that be toxic as well too? So we plotted, we analyzed the data looking at the possibility of both a linear model and this curvilinear model here. So the actual data is highlighted by this solid black line here. And as you can see, just looking at the raw data, it looks very clearly like a curvilinear relationship we're seeing here. Here's the sort of thicker dotted line is the linear relationship here, which seems to be describing this end of the curve fairly well, capturing the idea that high EOI is potentially toxic, but it's completely missing this idea that lower EOI may also be toxic as well too. When we fit the curvilinear model, we got a much better approximation of the data here, and as a bit of maybe a tangent here, this is probably why in all of our studies I would suggest it's worthwhile to consider the possibilities of curvilinear relationships. This linear relationship here is statistically significant, and lots had been written about it for about the 15 years after the study was originally done, before we did this reanalysis here. So even though you have a statistically significant linear relationship, doesn't mean that the data is actually not better explained by a curvilinear model. So, but enough of that. What we could take from this, though, is that low EOI among Mexican Americans seems to be just as toxic as high EOI here. They're relapsing much more than we would expect them to at the ends. And it's at middle levels of over-involvement where we might see caregivers going out of their way, being over-involved in a way that might be necessary when you have a relative who's suffering from schizophrenia. That's where we're seeing a protective factor here and seeing individuals being less likely to relapse. So getting to the idea of the pro-social indices of warmth, or pro-social indices of expressed emotion, looking at warmth and positive remarks. Well, these are typically ignored in studies. No one looks at them. And where we can blame that is actually this paper here, which is the very first study ever to talk about the term expressed emotion by George Brown and colleagues in the UK. And a bit of the history here, they found that positive remarks were not predictive of relapse among their sample of individuals with schizophrenia, and they found that warmth had a curvilinear relationship with relapse. Low warmth was associated with less relapse, and high warmth was associated with less relapse. And they sort of said, we don't understand why this is. These pro-social indices, they might be too complex, really, to study. I think they honestly probably threw that out there as hopefully an idea to stimulate further study of these topics, to highlight their complexity. But unfortunately, people in the EE literature have taken that too literally and said, okay, these are too complex. We're not going to study them at all. And now, nearly 40 years down the road, there are very few studies looking at these pro-social indices. Now, among the studies that have, we see some pretty important results. In schizophrenia, warmth appears to be negatively associated with relapse, but only in certain populations. The Lopez et al. Study was in Mexican Americans, Ivanovic was in Yugoslavia, and Bertrando was in Italy. These studies, we see clear relationships between high levels of warmth being associated with a lower risk of relapse among individuals with schizophrenia. If we look among Euro-Americans, no relationship between warmth and outcome in schizophrenia. So warmth seems to matter, but it only matters to certain people. What's interesting, though, is if we look at Europeans and European Americans, and we pull out some of these other variables of expressed emotion. So we look at folks who are low in criticism and low in EOI. And then we say, among that subgroup, is warmth predictive? Well, in that subgroup, it is. So if we look at a specific group of individuals who are low in some of these potentially negative variables, well, that's where we start to see warmth mattering here. In total, this does suggest that these pro-social indices and their relationship with outcome is complex, but I would like to think that this complexity should really be more of a call for research rather than a reason why we should ignore them altogether here. So if we're looking for another area to study in EE research, we can talk about the association between EE and health outcomes among caregivers themselves. Well, why might that be useful to look at? If we return back to this stress diathesis model of expressed emotion, what's useful to note is that these caregivers are experiencing stress. Stress, which we know is a risk factor for many, many psychological and physical disorders. We looked at this again among a sample of Mexican Americans in Los Angeles. And what we found, I should back this up. So we used the RAND health survey here. And these are the global composite scores of that, physical health, mental health, and global health. And what we found among these Mexican American caregivers of relatives with schizophrenia is that there was a relationship between EE indices and outcomes. In particular, emotional overinvolvement was higher emotional overinvolvement displayed by the caregiver was predictive of worse health in that same caregiver in terms of mental health, but also their general health scores. That's kind of interesting, and it presents a very nice symmetry because in this same sample, the index of expressed emotion that seemed to matter the most for predicting relapse among the relatives with schizophrenia was also emotional overinvolvement. So there's something very important about that measure in these Mexican American families, and that it's predicting poor outcomes among everyone in the family here. Warmth, we did find a relationship where high warmth was associated with worse mental health, but our subsequent analyses found out that that was really just due to the strong correlation between overinvolvement and warmth. And if you controlled for a caregiver's level of overinvolvement, that warmth was no longer predictive of any health outcomes. So EOI, emotional overinvolvement, seemed to be the key index here in predicting poor health outcomes. So the next question is, well, what poor health outcomes under these global indices? So here are the breakdown of the indices of the RAND, where we have physical functioning, role limitation due to physical health, role limitation due to emotional health, energy and fatigue, emotional well-being, social functioning, pain, general health, and then again our three composite scores at the beginning. Well, what emotional overinvolvement seems to be doing is leading to more role limitations due to poor physical health. It's not causing poor physical health, but it seems to make people, depending on their physical health, have more problems in completing activities of daily living. it was associated with worse emotional well-being among caregivers and worse social functioning. So if this is where the specific outcomes are that are associated with EOI, the next question is, well, what's causing these? We tested a model where we hypothesized that it was both burden that these caregivers experience, but also a lack of social support that may be mediating this relationship between emotional over-involvement and caregivers' health. And again, the picture that came out of this was very complex. For role limitations due to physical health, it was a lack of instrumental support in the caregivers' lives that seemed to mediate the relationship between EOI and poor health outcomes. For emotional well-being, it was again instrumental support or a lack of it, but also greater objective burden. For social functioning, none of these stood out as good predictors. And for the mental health composite score and the general health composite score, each one of these predictors seemed to have an independent effect in terms of leading to poor health outcomes among the caregivers. So there's a really multifaceted relationship between EOI and how it leads to poor health outcomes, at least among caregivers that we looked at in this study. So this might get back to the idea that this model here, the stress diathesis model, needs to be amended, and that we need to recognize that caregiving relatives in this model are at risk for themselves to suffer poor health outcomes due to expressed emotion in the family environment. The final area I'd like to talk about is the idea of high expressed emotion among professional caregivers, all of us here in the room here. Again, another great quote from Agnes Hatfield, where she notes that it must be remembered that psychiatric patients, and she's typically referring to individuals with schizophrenia here, also relapse when they're in staffed residencies, in psychosocial centers, and even in hospitals. If the Camberwell family interview predicts relapse well, then logic dictates that it should be used to assess staff in the clinics and hospitals and other patient services for their EE level and its relationship to problems of recovery. So the amount of criticism that we as professional caregivers show to our patients, the amount of over-involvement or hostility, might these also be associated with the course of illness here? As much as we might wish it wasn't true, high EE is displayed by professional caregivers, and it can get pretty high. In one study by Moore, 74% of the caregivers, professional health caregivers in their study, would be characterized as high in expressed emotion. So this is not a rare phenomenon here. There are people in our own profession who do this, and this is something we should be aware of. Why should we be aware of it? This was a meta-analytic analysis that I did for this talk, where I looked at the 3 studies that have looked at professional caregivers' level of expressed emotion and health outcomes among their patients with schizophrenia. And what we see from this, it's small. We only have 3 studies, so we should interpret this with caution. But there was a statistically significant effect of professional caregivers' level of EE and poor health outcomes among their patients here. So we can do damage, just like caregivers potentially could. I think that's important when we maybe throw around terms such as high EE caregivers, or say things that might blame caregivers for their poor course of illness. Well, we do the same thing. We probably wouldn't like it if people were blaming us as well, too. Let's recognize the complexity and nuance of what's going on here. So the mean Pearson's correlation across these studies was 0.36. If we look at the meta-analysis of EE as a predictor of relapse in schizophrenia looking at family caregivers, that same R is only 0.31. It's not a statistically significant difference between the two, but I think it's pretty noteworthy to note that professional caregivers' EE seems to be at least on par as a predictor or risk factor of poor outcomes, and potentially if we got more studies there, we might even find that it's even a better predictor than the family members' level of expressed emotion. So getting back to this idea of with or expressed emotion, should we continue to study this topic, or have we really got everything out of it that we need to? I would hope that this talk would suggest that there's much more to study in this area, that there are plenty of unanswered questions. And as this poor mother experienced here, we don't want to throw the baby out with the bathwater here. EE research has its problems, and it has been guilty of blaming caregivers for their ill relatives' poor course of illness. And that is something that needs to be corrected, and people, when they do EE studies, need to be cognizant of that, especially as they're writing up the data and making statements about these relationships between EE and relapse. But with thoughtful, careful description of the phenomena as it's actually occurring, I think we can learn very important things about how the social world, and in particular families, can have a very powerful effect, both positively and negatively, on the course of illness for individuals, not just in the U.S., but in the world. So thank you very much for your attention today.